This is going to be Pediatric Emergencies Pulmonary Part 3. Hypoperfusion Syndromes. Hypoperfusion syndromes are cardiovascular deficiencies that can lead to respiratory insufficiencies and eventual failure. Syndromes can cause respiratory insufficiencies. Common goals in all hypoperfusion syndromes: provide maximum oxygenation, create a favorable environment for heart to function properly. Hypoperfusion syndromes: rapid heart rate, rapid respiratory rate, decreased urination, delayed capillary refill time, and this would be because of perfusion, pale, cool, clammy skin, weak or absent peripheral pulse, impaired mental status or unresponsiveness, and the absence of tears when crying. At this point here, they are hypovolemic. Non-distributive shocks. Circulating volume is depleted. We can see this in hypovolemic shock, and that would be from diarrhea or vomiting, would be some contributing causes there. Hemorrhagic shock from bleeding. 80 milliliters per kilogram would be the total blood volume. If you spill more than 50% of that, that will generally thrust you into irreversible shock. Tachycardia, vasoconstriction, cannot compensate for the volume depletion. Remember, these guys don't increase the contractile force strength. Management goal is to replace vascular volume. In distributive shock, intravascular volume is normal, so the volume is normal. Vascular tone insufficiency to promote adequate perfusion, and this is all about the periphery. They do not have the ability to incite peripheral vasoconstriction. This causes poor perfusion pressures or inadequate tissue perfusion. Etiologies on this are going to be anaphylaxis, and that would be from a histamine release. Sepsis, and this would be from a battle ensuing between the bacteria and your white blood cells. And then neurogenic shock. This would have to be a high spinal cord injury above T12, would facilitate your inability to constrict your vessels. Management goal is to induce vasoconstriction. The sympathomimetic medications used to do this should have a high alpha agonism interaction. Examples of this are going to be Levophed, and then neostigmine or neosynephrine. Management of underlying conditions: sepsis and anaphylaxis. In the patient with sepsis, high multi-spectrum antibiotics should be utilized to get ahead of the bacterial infection. In anaphylaxis, stopping the histamine release, for patients that are refractory, getting ahead of the containment issue in the vessels. Cardiogenic shock. Adequate intervascular volume and vascular tone is present. The heart cannot provide adequate stroke volume. Common etiologies in the pediatric patient are going to be from cardiac injury, cardiac dysrhythmia, or congenital cardiac defect. Management goal is to maintain oxygenation and create an optimal work environment for adequate myocardial work. Give fluids and use inotropic agents. The inotropic agents are going to increase heart rate and contractile force strength. Remember, this part of the equation, even though we are increasing it but through pharmacological agents, may not be as forthcoming as it should be in the adult. Examples of this: dobutamine is very effective in the adult patient that is normotensive but has pulmonary edema. In the case of a pediatric patient in the same situation, the dobutamine may not give us all that we need. We're going to have to increase the rate as well. So dopamine may be a better candidate for these patients. Obstructive shock. Mechanism depends on etiology. General characteristic is the inability to pump blood secondary to some form of obstructive compression. Examples of this are going to be a cardiac tamponade, a tension pneumothorax, and a pulmonary embolism. Due to the fact that we have new parts and there's a decreased pathology, the pulmonary embolism should be low on our list for assessment, however, should be considered. Management goal is to correct the cause of the obstruction. Mechanism is case specific. Decompression, as far as the tension pneumothorax, pericardiocentesis in the pericardial tamponade, surgery may be in order as well, or thrombolytics in the PE scenario. Administer high flow, high concentrations of oxygens. Replace fluid volume as needed. Sepsis. Release of bacterial endotoxins causing a vasodilation and relative hypovolemia. Third space of fluids contributes to the hypovolemia. Inadequate pressure gradient causes tissues and organs to have hypoperfusion. Combined etiologies include bacterial infections and or viral infections. The battle that is ensuing, the endotoxins and the actual bacteria being released, they attack the structural walls of the vessels. The white blood cells as well. Releasing lymphokines, cytokines, and other toxins trying to kill the bacteria. This breaking down the vascular walls causes the container to lose its ability to constrict. This loss of containment is what gives you sepsis or septic shock. Management goals is to replace the vascular volume and encourage vasoconstriction and support the heart. Administer high flow, high concentrations of oxygen, give vasoactive medications, and use positive inotropes. The inotropes would be things like dopamine, dobutamine. Vasoactive agents would be things like levofed and neosynephrine. Drowning or near drowning. Epidemiology: more than 1,500 child deaths in the United States occur annually from drowning or near drowning. In water accidents, the victim saved, no medical attention sought, in 1 in 8 males or 1 in 23 females. The highest risks for drowning are going to be children under the age of 4, and most of these drown in swimming pools or bathtubs. Adolescents from 15 to 19 years, most of these drown in natural bodies of water like lakes and ponds. Pathophysiology: if we're considering them to be drowned, death would occur within 24 hours of submersion. So even though we've had a spontaneous ROSC coming back, if they still die within the first 24 hours, they're considered a drowning. Near drowning: submersion with more than 24 hours of survival time. Wet versus dry drowning. A wet drowning is whenever water is aspirated, and this is responsible for most pediatric drownings, washes out the surfactant and causes us problems with actually perfusion and oxygenation. On dry drowning, we have laryngospasm, which prevents the actual aspiration of water. However, the hypoxia and the full arrest that ensues still would be from a drowning source, just dry. There's no water that washed out the surfactant in the lung tissue. Management: consider risk of spinal injury, support their ABCs, follow your advanced cardiac life support protocols, initiate and continue care until hypothermic patients are normothermic. So we should not never call them until they are warm or have normal thermia. Epidemiology: and this is congenital heart disease. Congenital abnormalities is the leading cause of death in infants less than 1 year of age. Incidence of congenital heart disease are about 2 to 10 per 1,000 live births. Pathophysiology: congenital heart defects, often classified by pathophysiology, meaning defects that increase pulmonary blood flow, decrease pulmonary blood flow, or obstruct blood flow in some form or fashion. Defects that would increase pulmonary blood flow are a patent ductus arteriosus. The ductus arteriosus fails to close. An atrial septal defect. All of these will allow for the mixture of blood flow. Passage between the atria allows the blood to mix. Ventricular septal defect. Again, passage between the ventricles allows the blood to mix. And this would be oxygenated and deoxygenated blood. Pathophysiology continued. Defects that would decrease pulmonary blood flow, and things like tetralogy of Fallot, combination of 4 congenital defects, ventricular septal defect, pulmonary valve stenosis, which would increase back pressure. This eventually is going to make a hypertrophic right ventricle. It's a muscle, so the muscle is going to get bigger. Positioning of the aorta over the ventricular septum. This is because you have a VSD with the aortic opening where the septum should have been. So in the ventricles, most of the time, your aortic semilunar valve is kind of off to the side in the left ventricle. But in the patients with tetralogy of Fallot, it's right where the septum should be. Transposition of the great vessels. Position of the pulmonary and aortic arteries are reversed, which without the rest of these, example, ventricular septal defect, this patient is not going to allow for any perfusion whatsoever. Pathophysiology. Defects that obstruct blood flow. Coarctication of the aorta. The lumen of the aortic arch is narrower, and blood flow is obstructed. This can be caused from aortic or mitral stenosis, pulmonary stenosis as well. General management and concerns. Issues to be considered for all pediatric patients regardless of the pathophysiologies. Very high on this is going to be airway. Secure and maintain an airway as soon as needed and is possible. Consider a rapid sequence intubation for the transport environment. Be cautious and vigilant for accidental extubation of the patient. Continue use of sedatives and paralytics should be maintained throughout the transport. Use lateral restraints to minimize lateral mobility and the likelihood of accidental extubation. Vascular access can be difficult even for a skilled provider. Multiple vascular access options are preferable, venous routes and IO routes. And these are some of the venous areas. Harder to hit, they have more fat content, makes it harder to see the actual vessels. The saphenous veins are pretty large, right off of the ankle. The antecubital. In a pinch, external jugular should be considered. When providing peripheral access, a good way to identify where your veins are in the scalp is going to be to draw. Once we have venous access in the scalp, please secure it well. A lot of PD loops. A PD loop is in case they move. Tape being applied to each one of those. So if they pull it, it'll pull off one round of tape rather than the IV. General management concerns continued. Thermoregulation. Prevent heat loss. If we do have heat loss, use aggressive warming if it's warranted. A better example of that is unless we should watch our patient's thermic level and keep them normal thermic as we possibly can to prevent having to correct something that we have done. Hypoglycemia. The management of hypoglycemia is done with 25% dextrose. Whenever you're making that, you have dextrose 50% in the adult version. Squirt out half of it. Redilute it with your IV bag. Normal saline, not the dextrose 5% water. Whenever you get done with that, it'll be dextrose 25%. We do not use dextrose 50% on this population because it is hyperosmolaric. Correct hypoglycemia before transport. This ends part 3. If you have any questions, feel free to contact me. My name is Roy Smith, roy.smith@redlandscc.edu or smithr@emsa.net. Thank you.